Good morning, good afternoon, good evening. I wish you a warm welcome to the first worldwide webinar for Geistlich biomaterials in 2018. Today it is a real great pleasure for me to discuss with you some new options concerning connective tissue grafts. We're going to talk about soft tissue regeneration. So, the most visible problem in aesthetic dentistry is the soft tissue, because it's seen by the patient from the first glance. And if we have any visible problems, the patient is gonna complain about. The next step is, what are the consequences if we have missing vestibular dimension? And as you can see here, we have recession defects, visible shadows in cervical areas, sometimes missing interproximal papillas, and of course, from the outside, a loss of lip support. Today I'd like to concentrate on the biology, on the golden standard of tissue grafting, and finally, let's talk about GFG. First of all, a little more biology considerations. What is the background on implants and of course around teeth? If we compare on one side a tooth, on the other side an implant, we see similarities, but we also can find differences. And let's have a look at those two cone beam CTs, which from the first glance look almost the same. We have a very tiny thin bone on the buccal side, we have a prosthetically angulated implant, and we have a crown. But if you look at the clinical picture, you see from a soft tissue standpoint, we're gonna have more recession defects compared to the tooth. What's the reason for that? And the hot spot is the area where we penetrate the soft tissue. On the tooth side, we know that the bundle bone on the vestibular area is very thin, sometimes less than 0.5 millimeters. We have periodontal fibers between root and alveolar socket, which serve as nutrition for the bone and also for functional tooth mobility. And finally, we have above the alveolar crest a gingival architecture, which has a certain keratinization, which gives us a certain thickness of tissue, attached gingival, a free gingival margin, and this is done by 9 different supracrestal collagen fiber bundles. On the other side, the implant side, we should have, or better, we must have much thicker bone to end up with the same soft tissue thickness. We need an osseointegrated implant, and what we exactly don't know is where to keep the bone on the highest level. So it would be best to keep the bone above implant level. But we know from the literature this is the most demanding way. And finally, we deal with gingival scar tissue, which has almost no orientation at all. Some may say this scar tissue in the same thickness acts like a papilla or acts like the tissue around teeth. But we know from the literature that we need much more thickness to end up with the same optic. Let's talk about first the periodontal anatomy, so the biological side. We know these are the gingival fibers we have around the root, and we know if we would place a crown here, we can just hide the crown in the sulcus without damaging the biologic width. So which kind of tissue management can we do? We can do resective procedures, which are more or less gingivectomy or gingivoplasty. We can do apical reposition flaps. What can we do on the augmentative procedure side? We can place grafts. We can slide pedicle grafts, or we can move coronal or lateral advanced flaps. What about now the peri-implant anatomy? And here we have to divide, of course, between technological side and biological side, and I'd like to show you now more the biological side. We need a certain gingival thickness, which is divided into thick gingiva and thin gingiva. And the difference is the visibility of your periodontal probe. If you put in a perio probe into the sulcus and you can't see the probe through the gingiva, we say it's a thick phenotype. If you can have a glance of the thickness of the perio probe, we have a thin biotype. And we speak about a thin biotype with less than 1.5 millimeters of gingiva. What do we know from the literature? We know that we have more recession defects in thin phenotypes. And we know that if we have a thin phenotype, we have more crestal bone loss within 1 year as if we would have a thick biotype. What about the keratinization? In dental patients, we know that even if we have no keratinized mucosa, have nice aesthetic appearance. But in implantology, we know that keratinization should be around an implant because of aesthetics and hygiene. The minimal width of keratinized mucosa is about 2 millimeters. Keratinized mucosa is not attached gingiva. Attached gingiva is the gingiva which is attached to bone. Keratinized mucosa seals off bacteria. The more keratinized mucosa we have, the less plaque accumulation, the less inflammation, the less recession and marginal bone loss. And finally, on the lingual side, we also can keep off bacteria. Let's have a look at one case where we did surgery. A female 61-year-old patient. She was medically healthy. She smoked some cigarettes per day, were allergic to penicillin, but she had a recession defect at an implant on the upper left. Here you see the recession defect, and you see that looking with the perio probe, she does not have any fixed mucosa, and she does not have any keratinization at the recession defect. What did we do? We started to create more keratinization by putting in a Mukou graft. So here we split the flap, we leave the muscle. You can see that we stay strictly above the muscle. Then we remove the muscle of the periosteum. We do a vestibuloplasty. Now you see that was the vestibuloplasty, and now we suture in a Mukou graft like a free gingival graft with micro sutures to enhance the keratinization of that tissue. This Mukou graft has to be sutured in at all margins, and finally you see it looks like this. So this is the first step to get more keratinized mucosa. After 7 days, we take off the microsutures, and here you see how it looks after 3 months. Of course, we still have the recession defect, but now you can see that we have enough keratinization above these recession defects. So the next step now is the coronal advanced flap. You see, we can probe and we have enough keratinization. Now we cut for a coronal advanced flap. We raise a pure split thickness flap. We again remove muscle attachment if we find some. In such a case, we remove the keratinization of the papillas. Now we clean the surface of the implant. For that, we use the air abrasive systems. And in the end, we put a connective tissue graft in and place the flap coronal. Finally, we place some healing paste. So again, you see this is 2 weeks after coronal advanced flap. This is 6 months later. And yes, we have a slight recession again, because we didn't do any bony support, but look at the situation now between pre-op and 1 year post-op. This stays stable. So we know together with keratinized tissue, we can keep tissue in front. The 2-year results show the same situation like the 1 year result, and this should show you the result stays stable. What happens after gingival loading? So if we load an implant, we know that we end up with a gingival recession, which is approximately 1 millimeter. The more tiny the implant is, the more gingiva we have, and we know the thicker the soft tissue, the less recession defect. The gingival recession within 1 year is maximum 1.5 millimeters, and then after 1 year it stays stable. And finally, we know that the major gingival recession in immediately restored immediate implants is in the first 6 months. What about the interproximal soft tissue, the papilla? What do we know here? We have a spontaneous regrowth of interdental papilla. We know that the inter-implant papilla is protected if you place immediately an implant, or in this case 2 implants, and early loading of those implants. There is no difference if you use a distance of 2 millimeters between the implants or of 3 millimeters if you use the platform switching concept to give the soft tissue additional space. And we know that the mean height of a papilla between 2 implants is not like in dentate patients 5 to 6 millimeters, it is about 3.5 millimeters. Also here I can show you a case on that, a patient which is in 2004, 49 years old. She was suffering bruxism, she had pain at the tooth 1-1, which we have to extract. So we prepared the 2-1 for a crown, we extracted the 1-1, we placed immediately an implant, we did immediate impression, a connective tissue graft, and within 2 days we placed the final abutment. So in the bleeding environment we placed the final ceramic abutment with a connected long-term provisional. And here you can see what happens if you use living tissue on one side and biocompatible material on the other side. Within 6 weeks, we have a real ingrowth of soft tissue on the surface of the zirconium oxide abutment. You can see capillaries growing on the surface. In this area, we of course have to remove those tiny papilla tissues, and we go ahead with the final crown. You see, after 12 months, we place the final crown. And unfortunately, over 2 years, she got problems with the other side. So we had to place an implant beneath an implant. So we did the same procedure with immediate impression taking, as you see here. Within 2 days, we placed the final abutment and the long-term provisional without any occlusal contact in the beginning. This is the 1-week control. That's the 9-month control. Look at the papilla. It's not fully there at the moment. And after 12 months, we take off the long-term provisional, and you see in the sulcus on the right picture, this is the capillary ingrowth. This is the hemidesmosomal contact to the abutment. And that's now the final ground. And again, have a close look at the papilla. What happens when we disturb soft tissue? We're going to lose tissue during treatment. But we know from the literature, if you don't touch soft tissue anymore, you get that papilla back. That's 2 months post-prosthetic treatment, 2 final crowns, and almost a full papilla. This is after 5 and after 2 years. This now is the X-ray, which shows you the bony support between implants, which are closer than 3 millimeters in distance. And let's have a look on the long run. 6 years versus 3, 7 versus 4, 9 versus 6, 10 versus 7. We have a full papilla, even after 10 years between 2 implants. And that is dependent on soft tissue and, of course, on the bone. That's the 11-year to 8-year result, 12 to 9, and finally the actual result now 13 to 10 years. So now let's talk about the golden standard, the tissue grafting. The gold standard in soft tissue grafting at the moment is the connective tissue graft. Why do we need this connective tissue graft? We need it to increase volume, to gain keratinized tissue, to eliminate scars, to cover mucosal dehiscencies, and to augment interproximal tissues. There are 3 areas for soft tissue augmentations: the thickening beyond pontics, soft tissue thickness around implants, and finally, the most sophisticated part is the coverage of recession defects. We can classify all those soft tissue transplant, and as I already told you, the all-rounder around these is the connective tissue graft. So here you can see the direction of classification. We can divide into free and pedicle grafts and into epithelialized and pure connective tissue grafts. So the free and epithelialized grafts is the classical free gingival graft, or we call it the wedge graft or onlay graft. The free connective tissue graft, I told you, is the all-rounder in connective tissue grafting. And we have epithelialized pedicle flaps, which is the split thickness mucosal flap. And last but not least, the connective tissue flap, which is without any epithelium. Let's have a look at the anatomical considerations using connective tissue grafts. We know from the literature that the hard palate gives us a certain thickness, which is maximum 4 millimeters. But we can also take out tissue from the tuberosity to get much thicker connective tissues with less fat, less glands, but also less vessels. So just as a trick, if you need thin and large grafts, take them out from the hard palate. If you need thick and small grafts, take them out from the tuberosity. What about the healing? We know from the literature no patient wants to give a graft from the palate or even from the tuberosity, because we have a second stage surgery, which is sometimes more painful than the recipient side. With a single incision technique, we end up with the best healing result and the least pain. What about the quality and quantity of that tissue? And there is a nice study from Reiser and co-workers where you can see The more U-shaped the palate is, the thicker the connective tissue graft. Which means in a high palate, which is U-shaped, we can have up to 17 millimeters of thickness. In an average palate, it is 12 millimeters, and in a shallow palate or flat palate, we only have 7. Here you see this is a very high palate, and in the end of the palate, you might see also there is the channel of the artery, which we don't want to harm. Now let's talk about the surgical technique. And we have to talk about donor side more than the recipient side, because in the recipient side we already do surgery. What about the donor side? Here you see the harvesting of a connective tissue graft, which is in the 3 cutting technique. We do the first cut perpendicular to the surface, then we raise our blade up to 60 degrees and finally to 30 degrees to be almost parallel to the surface of the palate mucosa. Now we cut into deep to get a split thickness approach around here. We cut around the connective tissue graft we want to harvest. And now we mostly do a second split epiperiosteal to get out the full connective tissue graft. Again, you can see this in that video here. We have the first cut perpendicular to the surface. Now we do the second cut with 60 degrees angulation. And finally the third cut with 0 to 10 degrees, which is almost parallel to the surface. And finally, yes, you can take out, after uncutting the connective tissue graft, you can out this very, very high quality tissue. What if we have lack of adequate donor sites? In case of a flat palate, in case of a very thin connective tissue, in case of a very fatty connective tissue. In shallow palate, we have the increased risk of violation of the artery. The thickest palatal mucosa is approximately 17 millimeters, but we have to leave some tissue to cover the donor site. The extension of the recipient bed is limited. So we have a limited number of recession we can cover with the connective tissue graft. Now the scientific facts for the connective tissue graft. It is a minimal invasive surgical procedure with a high tissue stability. The connective tissue graft and the envelope technique allows you to cover a gingival recession with maximum 0.2 millimeters of recession after surgery, which is quite very predictable. The best enhancement we have if we combine connective tissue graft with coronal advanced flap covering the connective tissue. But in the end of the day, we don't really know about the long-term stability. The aesthetic outcome over several years is improved. And finally, the maximum possible long-term tissue thickness is about 5 millimeters. Above that, you can't only do soft tissue grafting, you need hard tissue. So what are the clinical limitations for the connective tissue grafts? It is the limited bioavailability. It is the limited bioavailability of the tissue. It is a sophisticated surgical procedure. And we have an increased morbidity due to the additional surgical site. Some patients tell us that they have numbness after surgery, and if you see this necrosis, there is sometimes also a complication at the donor site. And we have to tell our patient, of course, this might happen in up to 10%. Now, ladies and gentlemen, let's talk about GFG, the Geistlich Friendly Giant. We're going to talk about an alternative for connective tissue grafts, a very huge one, which is available just out of your drawer. Here you see the material. It looks very hard, but if you have it once in your hand, you will see it becomes soft, like a sponge. It is a resorbable, porous, cross-linked porcine collagen matrix, which production is standardized and controlled. It is not a skin of an animal. It is really produced collagen matrix, which has nothing to do with original skin at all. You can have it in 2 sizes, and I have to say, at the moment for dental use, the smaller size is quite enough. The indication is regeneration of soft tissue thickness beyond pontics, around teeth, around implants, and we hope in the future also for recession coverages. Let's have a close look at the matrix. Here you see the matrix in the REM. It has a very high porosity by cross-linking, which is above 90% of the volume. Within this matrix, you have a stabilization of the blood clot, and by stabilizing the blood clot, you can have a very nice ingrowth of fibrocytes. Even if you compress this sponge, it's going to uncompress after releasing. We have a very early revascularization. After 90 days, the matrix is fully integrated in the soft tissue. The volume is stable even after 6 months, and I'm going to show you clinical cases on that. And last but not least, we have a similar effectiveness compared to the CTG. Let's have a look at the surgical procedure. We start by thickening beyond pontics. Here you see a patient, 55 years old, healthy, and a missing tooth 2-2. He wanted to have a fixed aesthetic bridge. First, we talked about his recession defects at the canines, and you see the recession defects of more than 3 millimeters. We started to cover with connective tissue grafts from both sides of the palate. So this is directly after connective tissue grafting, recession coverage. And that's 2 months after grafting, and you see we nicely could cover the recessions, but we already took out 2 connective tissue grafts. And for the patient, it was not fun. And when we talked to him just to place another connective tissue graft for the pontic area, he refused. So what did we do? We wanted to enhance the thickness for a pontic area on the buccal side. So we took off the provisional and we used this Fibro guide, which we split it, as you can see on that picture. We trimmed it to the right size, and now we used a special suturing technique because there is one disadvantage of the matrix. If you would suture in this matrix like a connective tissue graft, it would just wrap out because the matrix is fragile. There is no real tension in that matrix because of the high connectivity of that tissue. It is very porous and it has no tension stiffness. So we used this special suturing technique just to give the tissue more stability, and Here you can see this, to just pull it into that pouch without any tension. Again, you can see this is the Geistlich Fibro Guide, which is adapted. Now we just put it with positioning sutures into the pouch, and now you pull it into the pouch. We close the flap, and this is the situation directly after surgery. You could see how nicely we could get vestibular volume, and that's 6 days after surgery when we took out the sutures. Still a lot of volume. Now we took out the sutures. You can see where the Fibro Guide is lying, and that's after 5 weeks. We still have almost the same volume like we had directly after surgery. That's the situation pre-op and post-op. Pre-op and post-op, without taking any connective tissue graft. What about soft tissue around implants? Here we have a 58-year-old female patient, and she wanted to have more gingival thickness around an implant which was at the moment still covered. Here you see beyond that tissue we have an implant, and we need for uncovering more vestibular volume. So what did we do? We used the flexible microknife to prepare a split thickness flap, You see the implant. We remove the muscular adaptations. So we prepare a pouch looking like this. Now we trim the Fibro Guide. We do the same suturing technique as I have shown you. We wetten the Fibro Guide, and you will see by wettening the Fibro Guide, it becomes thicker, almost 30%. So this is directly after surgery. Now we made a long-term provisional. 5 days later we take out the sutures. And this is now the long-term provisional with which she can wait until we uncover the implant 6 months later. And you see, even after 6 months, we still have buccal contour. This was before, right after surgery, and that's the 6-month control. What about recession coverage? This female 50-year-old patient had 2005 a full reconstruction. That was how she came in 2005. And she already was suffering missing papillas. She had perio treatment. We had to take out some teeth. And after treatment, she got 6 implants in the upper. And we placed all ceramic crowns on all implants and teeth. So this is the situation how we ended after 1.5 years of treatment, with no recession defects at all. And on the follow-up, here you see how we started, how we ended up, 2006. And that was the 4-year result, that was the periodontal 4-year recall. She didn't suffer any perio problems anymore. No recession. But after 6 years, you see at the left upper canine, a slight recession started. And after 8 years, it became greater. And the largest amount now is after 10 years, almost 2 millimeters of recession. Here you see the close-up of the recession defect. And we decided in such a tiny recession to start with Fibro Guide. A small video on that. Again, we do the coronal advanced flap by splitting the tissue. As you see here, it's full splitted except of the area in front of the root. Here we do the full flap technique. Now we stay strictly above the muscle. We prepare mesial and distal the pouch for the fibroguide. Now we clean the root with perio diamonds. We remove the papillary keratinized tissue to end up with a coronal advanced flap, and that's the fibroguide. You see the thickness of the fibroguide. We have to make it thinner. And the fibroguide now is put into the pouch, is sutured in with microsutures on the distal and, of course, on the mesial aspect. And now we suture the split thickness coronal advanced flap around the canine and close the vertical releasing incisions with microsutures, as you see here. So after approximately 45 minutes, you end up like this. And now we wait minimum 5 days, maximum 7 days to remove the sutures again. What about the indication, but also the limitation of the Geistlich fibroguide? If we compare a soft tissue graft on one side and the fibroguide on the other side, we have to say the soft tissue graft has one real advantage. It may be uncovered up to 30%, which gives us the possibility to gain also keratinized tissue. The fibroguide has to be covered. The disadvantage of the fibroguide is the fragile and risk of rupture. That's the reason why I showed you the new suturing technique, which is easy to learn, but you have to know new materials need new techniques. The disadvantage of the soft tissue grafts are the advantages of the Geistlich fibroguide. There is no risk of necrosis. Even if you end up with a dehiscency, you don't have a necrosis because you don't bring in living tissue. The handling of a connective tissue graft means you have to be careful because it's very slippery and you have to position it very, very precise to keep it in the right position. The Geistlich fibroguide is sticky, and this stickiness means if you once put in the fibroguide into the pocket, it stays there. The availability I don't have to talk about. We know you only have to open your drawer and you take out the package. I'd like to show you also a case on that. And I have to say this was our first split mouth case. It's a female 90-year-old patient. She was suffering hypertonia. She had a cardiac pacemaker. She had anticoagulant therapy, but she fractured her upper frontal bridge. She didn't want to have a long treatment. We had to do everything in one treatment. You see, this is her upper bridge, which was fixed to the neighboring teeth with composite. And when she came in, she told me, "Doctor, please do only one shot." That's the X-ray. And that's when we took off the bridge. You see both roots were broken beyond the gingiva, almost on bony level. Now you see the surgical approach. We took out both roots. For this we use the vertical pull-out system like the Beschnidt system, as you might see here. Now we clean the pockets, we clean the alveolar socket, we do implant placement with a guide. which gives us the possibility to immediately restore both implants with provisionals. And here we did the following. We put in both implants. We did augmentation of the socket with a bio-os material, and now we prepared two pouches, one left pouch and one right pouch. And in her left pouch, she got a connective tissue graft. As you see here, we have to take off the fatty part, we have to remove the glands. Then, of course, suturing now is very easy. You only have to go through the pocket, out the alveolar socket, 2 times through the connective tissue graft, back into the pocket again. You just pull it in with a positioning suture. Very easy to suture in. Here you see, you can pull without any rupture, of course. And with a microsuturing technique, we only fix the margins. On the other side, we use the Fibro guide. And here you see again the suturing technique, which is more sophisticated, of course. Again, you start in the bottom of the pouch just to come out in the alveolar socket. Now we do the positioning suture with a new technique. Some stitches through the Fibro guide and back through the pocket again. So although it is a new technique, if you have some routine, it only takes you double time. And now we wetten the Fibro guide and we pull it in. This is the situation after the surgery. That's the situation 5 days later. And now have a look at the 1 month result. This is the site with the connective tissue graft. This is the site with the Fibro guide. That's the 1 month result. That's the 3 month result. That's the 6 month result. And now look on the site with the connective tissue graft. We have a greater recession or a larger retraction of tissue as compared on the Fibro guide side. This Fibro guide side stays much more stable at the moment. What we did finally, we only took an impression with a transfer cap, and of course the lady is 90 years old. We didn't remove those abutments anymore, although she had some slight recessions on the buccal side, and we placed the final bridge. And again, look on the left side, the recession defect around the abutment was slightly greater, slightly higher compared to the Fibro guide side. Although we have the same bony support. That's the control, and still you see the site with the Fibro guide has the same volume as 6 months before. The 9-month control shows you that the connective tissue graft had slightly more recession defect than the Geistlich Fibro guide. So what now? The comparison about Mukou graft and Fibro guide. Because some of you may say, you already have an artificial connective tissue. And I have to say the Mukou graft is not a connective tissue graft. It is the same like a free gingival graft. It is allowed to have an open healing. It is allowed to seal bony cavities, and it is allowed to use in vestibuloplasty techniques, as I showed you already. For all those, the Fibro guide is not made for. About recession coverage, we have less clinical data for the Mukou graft, but we start now to have clinical data with the Fibro guide. The soft tissue thickness around implants we can easily do with the Fibro guide, not with the Mukou graft. And also finally, I'd like to show you the last case. of a 65-year-old male patient. He had an accident during kite surfing and he broke one tooth. So this is how he came in. And he broke that tooth. You see very deep, already a root canal treated tooth, and he also broke the post. So what did we do? We produced a long-term provisional as an extension bridge, like you can see here. We took out his old reconstruction in the front, and now we started, that's the implant, that's the fractured tooth. We started to remove the root. This is how we remove the root with a vertical extraction system, as you see here. Take your time for that. No damage to the tissue with this system, as you see here. Now we clean the socket, we place the implant, we fill the gap between implant and socket with a bio-os material. And now it's the most sophisticated thing between two implants to prepare the pouch. On the buccal side, we leave the periosteum to the bone. Now we bring in the Fibro guide with the suturing technique, as you know already. Now you see how we just pull it into that very, very thin tissue, into that pouch. And on top, to keep the keratinized tissue, we put a Mukou graft. This is the Mukou graft seal, which we put on top of the implant, and we suture it completely around. So this is a lot of biomaterial, of course. But if you have surrounding living tissues, you today can use the biomaterial to give the patient more comfort and more security in healing. Again, you see the technique, the final surgical site, and the implant we placed immediately. And this is now after 6 months. You see, we could keep keratinized tissue, we could keep the volume, and of course, we placed an implant. During uncovering procedures, you can just do an apical reposition flap and reopen the implant. And that's the situation directly after uncovering and abutment connection. 5 days post-op, we take off the sutures. I'd like to conclude. The thickness of the matrix should be 2 to 3 millimeter in maximum. The thicker you make the matrix and bring it in, it might end up with a dehiscency. So be careful not to bring in too much tissue. You should have a tension-free closure, and I tell you, it's all about suturing. You should know how to do a split thickness flap and how to do micro sutures. The Fibro guide is not a tissue or a matrix for beginners. The Fibro guide is more or less a convenience product for all dentists who know how to do plastic perio surgery. And even those who know to do connective tissue grafts need a learning curve in handling of a new material. Don't hesitate to talk with your colleagues about that, and don't hesitate to ask experienced colleagues how they do this. We have less complications during healing phases, a high tolerance to handling failures, but of course, then if you have some complications, you end up with less volume. The stability of the fibroguide is at the moment known as the same compared to the connective tissue graft. Finally, I'm looking forward now to your questions, and I hope you enjoyed this first worldwide webinar together with Geistlich Biomaterials. It was really fun for me to talk to you, and wherever you are on this really beautiful planet, live long and prosper, and I'm looking forward now to reading from you. Thank you very much. So, we made it finally, and I'm looking forward now to your questions. There is already one question from Toronto. What should I do if a dehiscence occurs post-operatively? Yes, of course. If we would have a dehiscency, you should do nothing because you only have a biomaterial. You don't have living tissue. There is no risk of a necrosis, but of course, there is a risk of a higher resorption. And finally, you end up with less tissue. But in case of a connective tissue graft, you have much more damage because of necrosis. So I would suggest, if there is a dehiscency, try to disinfect, to educate your patient, to rinse twice a day with a disinfection solution, and finally you check after 4 weeks to do a fibroguide or even then a connective tissue graft again. Any other questions? In your opinion, what is the better way to trim the fibroguide? Wet or dry? So honestly, it's a question of taste. If you want to trim it dry, you may use a sharp scalpel. You can just cut it, you can split it, and then you make it wet during suturing. Or if you want to trim it wet, you should use scissors. With the scissors, we don't at the moment really know if we damage the matrix by just squeezing it. So in my personal opinion, I would use the knife to trim it dry, and then I wetten it before I put it into the pouch. This is a really good question. Could you please explain once again your special sling suture for bringing the fibroguide in the right position? Basically, it's a kind of a meander suture to change tension into compression. We have seen during the learning curve, then if you would just sling the fibroguide with one stitch and you pull, you just read out the material. If you now meandering around the fibroguide, you change the tension into a compression of the fibroguide. So the fibroguide, for pulling it in, is compressed. It's easier to pull it in if it's wet. And then you even also can just take out this meander suture and fix it with a thinner suture. The meander suture should be done with a thicker thread material, because if it would be too thin, it would also cut the matrix. Any other questions of you? What will happen if the collagen matrix is not covered completely with a flap? It will, of course, dislute earlier. But anyway, as I told you, there is no real risk. There is only more resorption. Have you ever used a tunnel technique to apply the fibroguide? Yes, we did. The tunnel technique is the most sophisticated way. The tunnel means you have a very small entrance, then you have a pouch or a hollow scaffold where you want to bring in the matrix. If you raise a split thickness flap and you open it and you close it later for your learning curve to start with a fibro guide, it would be the better way. Have you got some experiences with fibro guide and the indication of recession coverage? I know you who asked this was coming late. We did this because I showed a case on that, and today, honestly, I can't show you this picture now, but today I had the follow-up, and we were really, really happy because the fibro guide does work under a coronal advanced flap. So at the moment, the questions are repeating, so feel free to ask. There is one thing I'd like to add. When you start with a fibro guide, you should start in an area where you don't need too much material, and start rather with less material than you need, because the fibro guide is going to expand during wettening. And we have seen over the last 20 surgeries that even if you put more pressure to the fibro guide, it will be less. The matrix needs its space. It is difficult to exactly adjust it, but it's better to have less fibro guide and tension-free suturing than to bring in a lot of material and you need a lot of force to close it. On the other hand, if you don't close it completely at the moment, it seems to be successful to place on top of the fibro guide a free gingival graft, or even we started with a Mukou graft, which is quite a lot biomaterial, but I have to admit, if you have a good nutrition by blood flow, we ended in most of the cases with a success. So on the long run, I don't see any more questions. Maybe it was enough information for you. Hopefully it was not too much information for you. I'd like again to thank you for your time together with me. And I want to introduce now the next webinar, which is held on May the 15th by my dear friend, Dr. Helmut Hildebrand, who's talking about 3D printed solutions for major bone augmentation. Helmut, I wish you all the best and a lot of participants in the next webinar. For you, I say thank you. Good evening. Here in Germany, it's totally dark outside. And thank you for listening. Thank you for watching. And I hope to see you on this beautiful planet again. Bye.